Now, may I invite Dr. Kamraj Singh, who speaks on non-periprosthetic fracture with TKR. Dr. Kamraj, you are not here? Okay. In that event, we invite Ankit Varsne for his topic, anatomical variation, a nightmare or a blessing in disguise.
So just good morning, everyone. The previous speaker just said that it's very difficult to hit a vessel. Now let's talk about these vessels. So I'm talking about anatomical variation, a nightmare or a blessing in disguise. This is a simple looking knee X-ray. Grade 4 osteoarthritis, 70-year-old male came to me for the total knee replacement. I did a total knee replacement. Next. Next नहीं हो रहा है. So this was the post-op X-ray, immediate post-op X-ray. I could see a small cement flake on the posteromedial side, but patient doing very fine. It was done just 5 days prior to the first lockdown of COVID. The follow-up was done on online consultations. The patient got the stitches removed at his home only. 6 months down the line, patient was doing very fine. Full movement, full range of movement. One fine day, that was 1 year post. क्या हो रहा है? क्या कर रहे हो भाई? किससे हो रहा है? इससे? अच्छा. One fine day, the patient came to me to the OPD telling, "Doc, I have some problem with my knee. The knee is literally locked in a 30 degree of FFD with further range only 45 degree. I got the X-ray done to see what is the problem. Everything looked fine, except in the lateral there was some sort of ossification present in the posterior capsule. I just got an MRI done because I was not understanding what is the actual situation. The radiologist told that there is some fragmentation in the inferior part of the patellar tendon and also the posterior part of the tibial condyle. And he gave a report of fragmentation of the posterolateral aspect of poly with irregular fragment posterior and in the infrapatellar region. I didn't understand why a poly will give way so early, and that also in the posterolateral corner with a well-balanced knee. So thought of starting the surgery. Now I would be explaining my experiences because that was not a situation where I could take some photographs. So we opened it up. We thought that since it is both tight in flexion and extension, we'll do a tibial revision only and the femur should go fine. We opened it up. The poly was absolutely fine. There was no fragmentation at all. This is the picture. We changed the complete tibial component, took some extra cuts, put the poly, and as soon as we released the tourniquet, boom. There was huge amount of bleeding that started happening over there in the OT table. The complete table, the complete area was flooded with blood. We immediately thought that, okay, this is a vascular injury. We called up the vascular surgeon. In Agra, we don't have in-house vascular surgeon. We called up immediately from the nearby hospital who barged in my OR and said, okay, this is a vascular injury. He told to just close it up and go posterior to see the popliteal artery. We explored the popliteal artery. It was absolutely fine. Then he just clipped some aberrant artery and said, okay, this is the aberrant artery, the vascularity is now restored, the bleeding will stop. We turned the patient and I could palpate the dorsalis pedis immediately after the post-surgery. So I looked up the literature because the clinical finding and what the vascular surgeon were told was not matching my thoughts. So I found that there was a paper telling that the aberrant anterior tibial artery and its surgical risk. So this is the picture that we have all read in our anatomy books. The popliteal artery bifurcates at the level of the inferior part of the popliteal triangle. But in some cases, this popliteal artery bifurcates into anterior and posterior tibial at the upper part of the triangle. When this artery bifurcates higher up in the distal femur notch, the anterior tibial artery goes very close to the posterior part of the tibial condyle, which was confirmed by the radiologist then that yes, if you can see the marking, the green marking, the artery was very close to the posterior part of the lateral condyle. And he said that he has missed it because he never thought of this problem. This is the immediate incision and the post-op X-ray. Patient doing fine after the surgery. Then the finding that if the vascular surgeon has clipped the anterior tibial artery, how could I palpate the dorsalis pedis immediately after the surgery? So that was the earlier variation, that the artery was close to the posterior condyle. The second variation was, as given by the radiologist, that the branch from the peroneal artery was supplying the anterior tibial artery somewhere down. So we had clipped it up, but from below the peroneal artery was feeding the anterior tibial artery. So that's the second anatomical variation in this case, which saved actually me. Now this is the movement post-surgery, 2 months. You can see full extension. The patient walking fine, but now comes again the problem. 3 months down the line, he came to me with a little bit of restriction movement again, and there is some calcification seen in the lateral part again. The post-op, 6 months down the line, the patient has started developing some FFD again, and if you see the movement of the patient, he is having a limp. He is not happy with my surgery. So I'm totally frustrated about it, but they are not now letting me do anything more, and even I am not interested in doing anything more. So the question to the house: what mistake did I do in the primary surgery that this patient developed such a deformity? And why is he developing such calcifications? The take-home message is, we should always keep in mind the vascularity and the aberrant variations that are present in human body. Thank you.
Thank you very much. Now, Dr. Kamraj Singh is here, so I invite him for delivering his talk on non-periprosthetic fracture with TKR.
A very good morning to everybody. We have been talking about periprosthetic fractures, but we must realize that sometimes we have non-periprosthetic fractures. We put our prosthesis in the knee, in the femur, but the one place where we don't put a prosthesis is the patella. So the patella is actually a non-periprosthetic fracture. Can I have the talk, please? Very good morning to everybody. Good morning to the chairpersons out here. Good morning to everybody. So, I came late in the night and I just got up, so I'm a little drowsy. But anyway, yes. Can we have this a full view? Okay, so where we are talking about a non-periprosthetic fracture in knee replacements. There's like all of us do a knee replacement at the patient with a good wound, good suture line, suture removal, everything is okay, patient is walking. But then what happens after a month, the patient comes back to you. He had a fall at home, a trivial fall. He was walking, he just fell and he broke his patella. So this is what he came back with: a simple transverse articular patellar fracture, 34C 1.1. Now what do we do? All of us will go and fix it. That is the natural routine. There was no underlying etiology, patient was non-diabetic, non-hypertensive, no other issues. So we just went ahead and we went and fixed the patella. But before that, we just went into some literature and saw what are the guidelines for a periprosthetic fracture. There are no guidelines for a non-periprosthetic. Non-periprosthetic fractures come under the normal guidelines where a fracture patella is fixed as it is. So we just went ahead and fixed it. We got a good range of movement and we were happy. The suture line healed, all was good. But the only thing remarkable was that the patient had a mid-vastus approach priorly before the surgery, and we did a patellar fixation. But he came back again after about 10-15 days with a completely loosened implant, and the fracture fragments had moved away. So we are back to square one. Now the markers were negative, culture was negative. Now this is what we are faced with. We have a patella which has been fixed once, and again he has come back with this. So what went amiss? We went back to history and we realized that he had a mid-vastus approach. We thought about vascularity being compromised. We had not opened the patient, but we went into the semantics of the surgery. Then we went back to literature and we thought, did we do something wrong with our approach? Did we do something wrong with our incision? So there are some general guidelines that you should do the oldest incision first or the most lateral incision first. If there's a transverse incision like a high tibial osteotomy or other, you do a vertical incision. Sometimes, now this is something which the plastic surgeons do, they do a sham incision, and after a few weeks they do a actual incision, or like we always do in the ankle, 6 to 8 centimeters gap between the incisions. The only lesson that I want you to learn today is that the lateral flap is hypoxic. That is the key word of today's talk. And if you are in doubt about opening the patient, so you can always call a plastic surgeon. Now this is something, you have 3 vessels on the right side and a couple of vessels on the medial side. 3 vessels on the medial side and a couple of vessels on the lateral side. When we remove the fat pad from the patella, we must realize there's an artery coming through it. Even from the quadriceps, there's an artery coming in. So all these are important vascular components. We went back again into deeper literature and we realized that the descending genicular artery, there's an artery which is coming just at the superior medial pole of the patella, which has to be protected. Here we have marked it again. The medial approach, when we do the medial approach, we violate all 3 arteries which are on the medial side. We open, anyway, just to cut it short, we opened the patella, we opened the knee, and what we found, that there was a loose implant, of course. There was necrotic bone on the medial side. The lateral part has united beautifully. So since the lateral part had to be excised, which you can see, we had a nibbler, we squeezed the bone and there was no, the bone was not good. It was giving a cheesy squirt. So we just removed the bone and we approximated the retinaculum to the lateral part which was remnant. So what did we learn from this was that the medial approach has its own pitfalls. Additional lateral release worsens vascularity. When you do a medial approach and you do a lateral release, you have to be very careful because it will take away the entire vasculature of the patella. And when you do a mid-vastus, you must take care not to go beyond 10 centimeters. And like we had here, sorry, can I have some water? Medial necrosis after, thank you, sir. So we could not fix the patella again. We just had to take away the bad bone, and we did a retinacular approximation. Yeah, I'm over. I love to put all knee surgeries, lower femur or patella, which are very difficult, in a 90-90 cast. So that is what we did. You can see the range that the patient achieved. There's 6 months follow-up. And the X-ray which you are seeing here, it is actually the patella, the lateral part of the patella which is visible. It is not the medial part. And it's so, you can see, so beautifully united, which goes to prove the same point, that the medial part was compromised and the lateral part was intact. So the lesson that we take, that the lateral flap is hypoxic, lateral flap. But the lateral, this part has remained. Can I have the videos? Oh yes, this is the patient, and the second video. So we got a good range of movement in spite of tackling with a patient where we were scared of an infection or things like that. We got a culture negative, we managed everything, but we put a 1990 cast. That was very important. And thank you so much. That is all that I had to say. Thank you.
Thank you very much. Now, may I request the moderator of the session, Dr. Subh Mehrotra, to kindly come on to the dais and call all the panelists for discussion.
Sir, may I call upon all the panelists now? Dr. Daksh, can I ask Dr. Daksh to come over, please? Then can I ask Dr. Umesh? Can I ask Dr. Lai? And can I ask Dr. Amit Verma? And all these speakers, please. Yes. Dr. S. Prasad is the chairperson. And Dr.
Dr. Anil P. Oman,
Dr. Anil P. Oman, please.
Dr. Chandan Kumar,
Dr. Chandan Kumar, please.
Dr. Amit Sharma,
Sir. Good morning, sir.
If there is any question or if there is anything to be clarified, please.
Yes, please. Dr. Maheshwari. You can take this mic. Maheshwari, you can.
Thank you, Umesh, for that very nice starter. I thought I'm going to learn something in this lecture because we all doing all kind of infiltration for many years without even thinking what we're doing is right or wrong. The two things I noted differently. My concept was you cut and you infiltrate the area that you've cut. That's it. No synovium, nothing. So one, what is the logic of infiltrating everywhere where actually you have not put your knife? So those nerves are okay. Second is, what is the status of putting in a catheter? So a lot of these intravenous medication creates a lot of havoc to the patient. So rather than just one-time infiltration, there was some time back a concept of putting a catheter there, so that let the knee be quiet for 2-3 days and avoid opioids, etc. What is the second thing? First thing is, why are you infiltrating other structures which you have not cut?
So, very nice question, sir. So, synovial predominantly is inflamed, often defined inflamed. So, technically, this is inflamed. So, initially, if I say, that is also a source of pain. So, if I'm infiltrating it, the initial post-op period, till the rest of the medicine is taken over, the patient gets a pain. So, that's why the synovial. And how the catheters, that's the entire reason I shifted to this cocktail and block, because I'm very wary about these catheters, because they keep on doing a lot of funny things. You have to be monitored well. Sometimes you have a lot of motor weakness when the catheter is there, so it's not mobilize the patient. So the reason, that's why I'm not at all, we don't do these epidurals, just spinal and this cocktail, that's it. No catheter, no umbilical catheter, no catheter in the knee, no catheter in the extra canal, no subcervical canal, no catheter, just it. And with this surgeon administered canal bar, I've shifted to that, and I cannot like my anesthetist giving canal advice. So when people are doing it, I'm amazed at it. But this is, I think this is more in my control.
Just a quick point. Yeah.
See, my anesthetist is giving us the continuous canal block. She puts in a catheter, and the patient is so comfortable actually because we are not interfering with the motor also, and you get a very good block with the continuous canal block. Normally I won't do it, but I have seen surgeons, I have been listening to those surgeons, and what they do is they're buying. It goes diagonally across right from the incision side, and they get a wonderful
Just a quick point to add, Dr. Unmesh. Just a quick point to add. Now, I think the basis of, I think Dr. Maheshwari also added that, I think our pericapsular infiltration, majority is to go into the posterior capsule. I think that is where the basis of our, even Dr. Anant had propagated. So I think a lot of it goes into the posterior capsule. And addition to which, we are talking about an adductor, or even recent literature showed IPAC, which means specifically for the posterior capsule. So this is all done in addition to our infiltration on the capsule. So if the anesthetist does it, they do it under ultrasound guidance, they know where they are, and they can put in the catheter. Reservations may be there for everyone, but I think, like you also pointed out, they're putting in the catheter, either single shot or a catheter placed, but under ultrasonic guidance, that would be better and probably a good solution to your 48 hours or 72 hours till your overlap comes with other modes of analgesia, anesthesia.
Drugs will be there inside the kidney. Because there will be another possibility initially that you drugs will be take out of the kidney. And after that, all the nutrients which are there are likely to persist there for 6 to 7 hours. On each time, this is a spinal related to the body.
So we don't do it under epidural. We stopped epidurals for some time, either under spinal or if depend that the anesthetist decide. But I think for pain management, it's completely switched to anesthetist-induced adductor block. So I
So there's a shift now on the adductor canal block. Now these anesthetists have shifted to a dual subclavicular block, and which is giving about we don't put catheters in it because there was one case which I saw in which the catheter got intermingled with the saphenous nerve, and they had to go for the in-house surgery to remove that catheter. So they stopped using the catheters, and these dual subclavicular blocks, they give a time period of 24 to 36 hours. The patient is absolutely pain-free, and it is done only under ultrasound guided supervision.
think bottom line is ultrasound guided. Dr. Hemant, do you have anything to add?
Perhaps it's important to bring out the variations in these techniques. I think only variation that I could find, with yours is obviously the composition of the fluid. I don't use depomedrol in that, but I add clonidine to that, and obviously ropivacaine. I divide my fluids, 60 cc fluids, into 3, 20, 20, 20. 20 cc goes in before the implantation, that goes into the medial meniscus floor, posterior capsule, lateral meniscus floor, and the patellar tendon. And then the rest 40 cc goes into the retinaculum and quadriceps retinaculum, and I do not infiltrate the lateral tendon. The important learning point here is that I have burnt my hands infiltrating into the lateral skin flap. I do not infiltrate into the lateral skin flap, but only the medial skin flap, because otherwise there is skin healing issues. The vascularity on the lateral side is poor. And second issue is with respect to the depomedrol. We don't have depomedrol in the fluid. We add clonidine and adrenaline, obviously, as you did.
Any other question you want to know?
Other variation was using 16 gauge Venflon. I find 16 gauge to be too big. I use 20 gauge Venflon, and that I find to be stiff enough. At the same time, see, my worry is with 16 gauge is that suppose accidentally you go in the midline and actually injure a vessel, you're going to cause a much bigger injury with 16 gauge Venflon than a 20 gauge.
Of late, patient controlled analgesia is also another thing which has come up. You use that instrument, and then people whenever they are feeling pain, they use morphine.
My question to Dr. Unmesh. Dr. Unmesh, you are using depomedrol. Now it is a depot preparation and it will stay. We are all, as orthopedic surgeons, the infection is a dreaded complication. So how long do you give a antibiotic in your protocol?
So same 3 shots of IV antibiotics, and if the patient has got a Foley's catheter, just put a oral antibiotic. With the depomedrol, if you are getting your CBCs done, you will frequently find that the total counts are raised. So that's why I don't get the CBCs done, because if you put a depomedrol, I've often found maybe like 3 to 4 out of 10 that the total counts in the range of 19,000-20,000. So we had a lot of discussion regarding this, but it is pretty rampant. I don't know how many of you have experienced this, that anybody has experienced total count going up with the depomedrol? It does. So don't be scared about that. And the routine, just 3 shots of IV antibiotics, 1 pre-op, 1 in the evening, next in the morning, and then oral if the catheter, Foley's catheter is there. Otherwise, no other, nothing specific.
Yes, Dr. Mukesh.
Yeah, so we do infiltrate. May I know how long it lasts? Because many times we see as soon as spinal goes, patients start complaining of pain. So, how long does that infiltrate last? And is it
Very
only for
interesting observation,
short-term
because
gain,
it varies
only
from
for
patient
few
to
hours?
No, it
Only
varies
for
from
few-
patient to patient. See, if you do a surgery in the morning and we infiltrate, nowadays we give the adductor also, the patient is able to do SLR by the afternoon or evening without much pain. But that the
But
threshold
is it the
varies.
infiltrate or your adductor block, which
Both,
is working
both,
for
both.
that SLR?
Yeah, so that's a problem. So always the pain team wants to say, no, you're giving infiltration, we'll give the adductor block also. The patient is able to comfortably do an SLR, but always, I'm sure Dr. BDC and also Dr. Hemant, I'm sure the different threshold is different in various. Now the potential is ambulation, correct?
Yeah.
Dr. Hemant?
The most important advantage being that you make the patient stand up within 3 to 4 hours after the surgery. As soon as the spinal anesthesia recovers and patient is able to do active SLR, get them to stand up and take a few steps. It's a huge game changer as far as the patient's psyche is concerned.
I think,
And it lasts about 24 hours.
Can I just ask for a show of hands? Have everyone using epidural or spinal? Spinal GA?
Only spinal.
Epidural, how many for epidural now? Epidural. So a lot of us still with
unilateral
epidural.
it's fine, spinal, but for bilateral?
Epidural?
Yeah.
Epidural.
No, we do bilaterals only with infiltration. We have 120 cc's fluid
No, do you
made, slightly lower dilution.
epidural or
No
spinal?
epidural, no epidural. For
I
last
think-
almost 10 years now.
Correct. So I think a lot of people have moved away from epidural because of various issues with the epidural. And that's what, Dr. BDC?
So the first thing is that I don't do bilaterals. So there's no question of epidural there. And I think the best part, like I can repeat that if you give an adductor canal block, the patient can walk in the evening. That is, I think, an important thing. Steroids, I avoid using steroids in diabetics and in rheumatoids because I'm a bit worried about the immunity part.
Dr. Umesh, your bilateral epidural?
I use spinal epidural. Epidural is only SOS if required. It's not been used 99% times, and I kind of block.
Mudit, Dr. Mudit? Epidurals or spinal?
Just one comment.
Just quickly, because we'll just take spinal.
I'm a little cautious about the PSA, patient controlled anesthesia, because they tend to over-medicate. Yeah, PCA, sorry. They tend to over-medicate with morphine.
Dr. Prasad, I think, so basically, if people are, there'll be a mix of, I think we should combine infiltration with the agreement of all the panels.
I think that speaks about the variety. And everything works, and you can't have a rule of thumb for everyone. It has to be patient specific. You have to see what your patient desires. Like if you're doing bilateral, yes, epidural does help. So nothing is contraindicated as such. This is the only thing I can say. So do whatever you can. All things are established, but do judiciously. Yes, the advantages of adductor canal block which we are seeing, and it is prudent to use some, your anesthetist should help it, how to do a good adductor canal block. But everything comes at a cost. So just be careful of that.
So the take-home message would be, sir?
Yeah. Yeah, as this is what we desire. We want patient to walk the same day in the evening. That is our we desire. How to get it done, you decide, but you have to change your strategy in some patients where you will not like the patient to walk today. Maybe yes, you can wait for one day. One day is not going to make a lot of difference. So you have to make it patient specific, not surgeon specific. नहीं मैं तो सब में ऐसे करूँगा. No, that's not true.
So now, do we have any question from Dr. Lake? Factors affecting and overcoming difficulties in total knee replacement surgery?
I think that was a very concise and very scary also, but I think all the joint surgeons should be scared when they are putting up a knife. So I think any questions about that?
Well, Dr. Like, you talked about initial 6 millimeter cut. Initial 6 millimeter cut. Do you investigate preoperatively your patients about having osteoporosis?
No, sir. For osteoporosis, we don't do that. Regularly, we don't do it unless and until it is explicitly, seen on the X-ray that it is grossly osteoporotic. In that condition, yes. Because ultimately, it's not going to help in any way.
But I think, specifically
rheumatoid
rheumatoid,
arthritis.
must ensure
Rheumatoid
because
arthritis.
your strategies may change if you know that how this osteoporosis. Even adding a stem can be savior at times. When clinically it doesn't look like an X-ray, but once you know how the bone density is, and clinically also when you cut the tibia, you can feel how the bone is. But yes, osteoporosis is a very important finding for post-operative.
Just one comment here. There was a comment about the saw blade thickness and taking 6 millimeters initially, that becomes 8 millimeters. The variation, see what usually happens is that our instrumentations are used for thousands of cases and they slot become wider. The original design is for 1.27 millimeter wide. 1.27 millimeters is what usually the slot thickness is. That becomes more than 3 millimeters, that's different. But if you use a thinner blade, say most of our ideal recommendation is to use 1.2 millimeter thick blade. If you use a thinner blade, there is more chance of deviation. So ideally, you should not be using blade that is thinner than 1.2. You insist on a blade thickness of 1.2 millimeters. That I think is critical.